I'm sorry I'm not there. I'm hopefully going to see the Eagles. I can see everyone in the audience. Hopefully I'll see the Eagles beat the Patriots. So do I have any fans in the audience for the Eagles out there? A few.
Yeah, we got a couple.
A couple, maybe 2 or 3. Well, I can't see Reggie's slide, but I just have to say that I agree with everything he says when he talks about the potential. And I think there's great potential in the techniques we have for deformity surgery with MIS techniques. I think imaging, implants, techniques will evolve. But today we're not there. So I want to focus on what we know and what we're doing today. I am an open surgeon. I do the lateral approach. I don't consider myself an MIS surgeon. I do percutaneous screws. I don't consider myself an MIS surgeon. I don't do tubular surgery. When I do deformity surgery, it's clearly open, and I have great confidence that I can accomplish my goals of what I do. Those are my conflicts. My one conflict is I don't believe in MIS deformity surgery. So Reggie just went over exactly why we do MIS, and he's absolutely right. There is less blood loss. There's probably less pain unless the patient's in the OR for an extended period of time. 2 weeks ago, a seminal article in JBJS said outcomes for deformity surgery have nothing to do with the amount of tissue dissection. It has to do with the time under anesthesia and in the operating room. So we have to stop getting confused that we have to make a smaller incision. We have to expose patients to less anesthesia, and we have to get them off the operating room table. MIS does shorten the length of stay if you normalize, but can we really use it for deformity? We could do it great for simple regional problems of the spine, discectomies, decompression. But we're dealing with global malalignment. When you take someone with an SVA of 15 when they should have an SVA of 5, when you have someone who has a significant global deformity, can I rely on the techniques that Reggie just described? Because if I get it wrong, if a patient should be living in an SVA of 9 or 5, and he comes out of that operating room with an SVA of 15, he's not going to be happy, and we'll go right back to the operating room. And who cares that he has 2 small incisions when I could have done a larger one and got the patient back in line? So these are the typical things that we see now. If we don't get the parameters that we understand today, and believe me, when I tell you that these numbers are changing every day, I go to a spine meeting every 2 weeks, and every 2 weeks someone else has a new measurement. So we're just learning more about deformity. But what I've seen in my own practice, I can only get so much from a lateral approach. I can only get so much from percutaneous screws, but I can't get the amount of correction that I need. I don't have the leverage to change the parameters such that I could take someone with an SVA or global malalignment of, say, 22 and bring them back to a normal SVA. I just don't have the ability to do that. I don't have the ability to do a triplanar deformity. I can't do it. And when it comes to fusion from a percutaneous, unless I have interbody support, we don't really have the biologics now to go posteriorly and lay bone graft posterolaterally. We just don't have it. And, a lot of people say, listen, if you talk to Larry Lenke, he's a posterior surgeon. He has said many, many times, I've given up on anterior surgery. It's a waste. And he only does interbody procedures on lower 2 or 3 levels. But if you have to really fuse from T10 down to L3, you really need to have exposure to get that. And do we have the data? Now, Reggie, I didn't see his slides, but Reggie mentioned some data, and I read those articles a little bit differently. So let me take you through a tour, and we have Neil in the audience, and we have a lot of the speakers in the audience. This was, I think, the first article that really talked about deformity surgery, and I thank Neil. Neil is a pioneer in minimally invasive surgery. He has great talent. And when you read the papers carefully, this is one of the first papers, 12 patients. He didn't talk about outcomes. He didn't talk about sagittal balance. He didn't talk about pelvic parameters. But what stands out in this paper to me is the deformity cases had an average of 3.5 levels, and they took about an hour a level anteriorly. That's a lot of time. Mean hospital stay, 8.6 days. You should be able to get a deformity patient home in 2 to 3 days. And if you look at the literature closely, a lot of these papers show outcomes that we would not consider optimum. This was, I think, the best paper from Wang. Wang discussed the concept of a ceiling effect. He looked at MIS, he looked at anterior standalone, and he looked at hybrid. And if you look at each category, coronal plane, standalone's 23 degrees compared to open 55, sagittal plane 5 degrees for SVA compared to open 16.6. So he talked about these techniques improving, but there's a clear ceiling effect to MIS surgery. The lateral approach, I love. When I have a junctional breakdown above an L4 to S1 fusion, nothing better. L2-3, nothing better. L4-5, I have headaches. So can I really change the coronal curve? Can I really change the sagittal malalignment? Can I decompress anything more than mild to moderate lateral recessed stenosis? Well, let's take a look at the literature. This is one of the first papers that came out. You see the date 2010. 8 patients, no follow-up. Mean lumbar lordosis, 47 degrees pre-op. It was 40 degrees post-op. These patients actually became kyphotic. And when you read the paper and you look at the patients lost 40 degrees of lordosis at certain levels, and this was published. This is the type of literature that comes out. And if you look at the literature and you look at the pictures provided, there was not one lateral x-ray. And this is me putting this talk together. And then you look at Juan Urabi's paper. Juan may be in the audience. And again, this is 2010, 25 patients, 11-month follow-up, 6.2 days in the hospital, an hour and a half per level, didn't discuss sagittal plane deformities. And again, if you look at the x-rays in the paper, remember, I write papers for a living. I take the best case I have and I publish them. These are the best examples that Juan placed in his paper. These are not very, very, pictures that you'd want to have your patients come out. Another paper by Neil, 28 patients, lateral into bodies. He had a decent Cobb correction of 22-7. But again, he didn't talk about any sagittal alignment or pelvic parameters. And again, the pictures that Neil placed, they really don't show off any technique. If I saw these in a deformity journal, I'd be like, listen, that's not very impressive. And 30% of the patients had persistent sagittal malalignment. Now, how can we really look at who's a candidate for deformity surgery? I thought this was great. This looked at segmental, regional, and global alignment. And at the end of the day, you may be able to change a little bit segmentally, possibly regionally, but the global balance between MIS and open, no difference at all. I thought that was sort of interesting. How about a meta-analysis of literature? This was a paper by Juan Uribe. He looked at 23 articles, multiple levels fused, and lumbar lordosis only increased by 3.4 degrees using the lateral approach. And if you look at the data carefully, he combined it with anterior interbody fusions. So that's not much at all. So these are long procedures, they're expensive procedures, and I use a lot more equipment when I do a lateral approach than when I do an anterior approach. Now, this is another study by the International Spine Study Group, and they have a whole segment that does minimally invasive surgery. So this is the ISSG database, and they did something really interesting. They looked at what they call the Schwab Global Alignment Modifier. What happens if you do this on people with no deformity, people with a little deformity, or people with a lot of deformity? So the next slide shows the blue means that you have gotten them back to where you want to be. At the bottom, you see 0. 0 means they don't have a deformity. Well, they stay relatively aligned. But if you see the double plus, that means these people had significant deformity. And guess what? 7% continued to have significant deformity. So these minimally invasive techniques, even though we have navigational systems to place their spinal implants, the literature being published by people who are experts at MIS don't support that. My fellow at Cleveland Clinic did a matched cohort study of 33 patients where they did a lateral or anterior interbody and a posterior compared to posterior alone. No difference at all. Pelvic tilt, SVA, no difference. And this was a matched cohort. So when you begin to look at the real scientific studies that put things together, you don't see a difference. Now, what about these more aggressive wedged cages? Now we pay $2,000, $3,000, sometimes $4,000 for these. Average increase in lordosis 2.8 per level. That's not very much if you can get 0.6 degrees, not much at all. And if you look at studies that looked at these cages, this is a paper published, 8 patients, 1 severe subsidence, 6 end plate fractures. And if you had an end plate fracture, you only realized 23% of the angulation. So even these cages, even though when we come to these meetings, we see incredibly challenging cases, they look like they underwent a total remake. When you're doing it in practice and when you're publishing, we don't see that. Now, PJK makes the most sense for MIS surgeries. And again, a study group paper that came out and said it works, it's great. But if you really look closely, and if you normalize the data, matched for levels, MIS and hybrid were exactly the same. Reoperations for MIS and hybrid, exactly the same. When you get away from, well, the cases are different, but when you compare subgroups, when you match them, they're not any difference. What about revision rates? This is another International Spine Study Group paper that said revision rates are decreased. But if you really look closely, the reoperation rates were exactly the same for MIS and open, no difference at all. And they spent 2.5 times more time doing an MIS procedure. And I'm not mentioning the fact that a significant amount of these patients and physicians were exposed to radiation. So that's something we have to keep in mind. The last paper I want to talk about is cost. It costs a lot more money, in my opinion, to do an MIS procedure because you're using more materials. This was a study that came out by Rick, and I think Rick's in the audience. It said, listen, it's cost effective. You have decreased length of stay, EBL, and cost. But if you really look closely, and all the variables showed that MIS, less days in the hospital, EBL less, cost less. But if you took them by the number of levels fused, there was so much less in the MIS compared to the open. The parameters were so much better improved in the open. The Cobb angle, 27 versus 37. The PT, 25 versus 29. The mismatch, 19 versus 26.7. And if you look at all the other variables, SVA is so much better in open. Lumbar lordosis so much better open. The pre-op to post-op changes in lumbar lordosis so much better, as well as the outcome measures were better in open. So when you start to read the granularity of these papers, open procedure blows it away. And as Juan said in a great paper that he published in 2014, the literature is just lousy. So when you talk about the theory, it makes sense. But when you look at the literature, it doesn't make any sense. And I want to end with this one slide. This is a slide by the study group that said, listen, we have a great understanding of MIS, and here's the algorithm. I want everyone to stare at that slide. It basically says, if you don't have a deformity, you could do deformity surgery with MIS. Everything else is red. No, 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 no. So in summary, I don't think we have what we need yet to do what we need to do with deformity surgery. It is changing. I agree with the new types of imaging studies, navigations, but we haven't figured out how to make the technique so we can get the same outcomes from an open procedure. Thank you.